There we go. And so, Dr. Erin Chan, I will let you take it away from here, and I'll just mute myself as well.
Okay, thank you. So let me just share my presentation with you guys. There we go. Can you all see that? Thumbs up? Okay, so good afternoon, everybody. My name, as Terry mentioned, is Dr. Erin Chan. I'm one of the physiatrists here at GF Strong, and I work on the spinal cord injury unit here. I also do an outpatient clinic where I do intrathecal baclofen, which is something that I'll be chatting about later as well. I've got about 25 some odd slides to go through with you guys about spasticity. It can be a little bit of a complicated topic, but certainly something that a lot of you may have experienced before or may still be experiencing now. And I'm hoping that I can make it a little bit easy for you guys to understand, just in regards to what it is, what we should do about it, etc. So there are a lot of slides, as I mentioned. I tried to cut out as many of the technical terms as possible. You don't necessarily always have to follow the slides. If something doesn't make sense, just listen to what I'm saying as well, and hopefully I can make it clear. If for some reason, again, if there are questions, feel free to add things to that chat, and we can deal with it as we can. Okay, so feel free to ask any questions that you have. So let's see how I go next. Okay, so these are sort of the objectives that I wanted to get through today, and hopefully these are some questions that you may have thought about. And hopefully by the end of this presentation, you'll be able to have answers to them. So I'll start off by what is spasticity? Why do people get them? How do people get them, and are there triggers? What are the complications of it? Is it always a bad thing? And why and how do we treat it? Okay. So first of all, what is spasticity? I was thinking about how I can describe this as simply as I can, but it is a condition that affects motor function and sensation. So your ability to move, your ability to feel in an uncontrolled way where you have this uncontrolled muscle tone. It's due to an injury that results to an injury with the nerves that lead from the brain or in the spinal cord. So typically speaking, your brain is connected to all of your muscles in your body through the spinal cord. And that spinal cord has nerves that go out to all of your muscles. So an injury anywhere from the brain or the spinal cord can lead to this uncontrolled motor function, uncontrolled muscle tone, and that's a part of what spasticity is. So what are some of its characteristics? So again, it's this temporary or continuous movement of your muscles. It's this muscle activation that happens. And sorry, that should say involuntary muscle activation. So it's this uncontrollable muscle tone that happens in your body. You may see it in your upper extremity. You may see it in your lower extremity. It can also be in other areas of your body that you don't see. Sometimes people have it in their bladder, in their abdominal muscles, etc., which can lead to this contraction of the muscles that can be problematic. Some people also see it as showing up as clonus, something that you may have seen where you continue to have this movement that goes like this, and that's a part of what spasticity is as well. It occurs in about 80% of those who have spinal cord injuries, but certainly it's not only seen in spinal cord injuries, it's seen in other conditions like multiple sclerosis, stroke, cerebral palsy. Any injury that somebody has within the brain or the spinal cord, as mentioned, can lead to it. It can have a varied degree of effect, so it can be quite mild, where it doesn't really cause problems for people, doesn't really affect their function, and then it can be more severe. So if it's increased in intensity or frequency, it can also affect function or cause pain. And that's how oftentimes people will describe it. They don't know what spasticity is, but they know that they have pain, they know that they have tightness, and they know that they have this movement that they can't really control. And that's how oftentimes people who have spinal cord injuries will say that they have this issue. And then we start to tease it out and figure out how we can best help with it. Okay, so the next picture I have is just sort of a graph of what the trajectory looks like when people start to develop spasticity? Sorry?
Hey, Aaron, just,
Yeah.
sorry. I have a smaller screen, so if anybody else has a smaller screen, I can't see the far right. So just if you could move over when you're describing it, that would be awesome.
Move, move over the,
Yeah, so I basically only see where it says, like where the after spasticity stays stable. Yeah,
yeah.
so when you're describing it, if you just follow over to the right, I guess, that'd be
How
great.
do I do that?
You just did it, so I think that worked.
Oh,
You just
like
scroll.
this?
Keep going. Can you move the slide over somehow? I don't know. Maybe
Oops.
no one else has a problem.
I can,
Oh, well, I'm sure it'll be fine if you just describe it, and then we can always.
I'll just go like that.
Oh, yeah, that's perfect. Okay, great.
Is that better?
Yeah.
Okay.
Yeah. Thank you.
So if it's ever a slide like that and I don't notice it, let me know, and then I can just kind of quickly edit it. Okay. All right. So this is just a little bit of a picture graph of what spasticity looks like. So can you see my mouse move? Yeah. So over here is the initial injury. And I would imagine that most of you guys are a little bit out in regards to the initial injury. But I see people in Vancouver General Hospital after they first had an injury. And there's this period for about 6 weeks or so historically where somebody is in spinal shock. And that's essentially where your body's in a bit of shock, not knowing what's happened to it in regards to the injury. So the body kind of shuts down. There's little to no motor function, sensation, reflexes, or spasticity below the level of lesion for that first 6 weeks. And that's just an average. It can be shorter, it can be longer. But shortly after that, people start to redevelop some muscle function, some muscle tone, some sensation, and some reflexes. That starts to increase as see on this graph, and that's sort of what this is described as natural development. And it levels out in that what you are experiencing will be the extent of what normal is to you. Then as you go over and see this sudden increase in spasticity, oftentimes after it has stabilized, if it increases, there's possibly a reason why that's happening. And that's where, hopefully this presentation will give you some insight, but also touching base with your team, your family doctor, your therapist, or somebody like myself can help to figure out why it's changing, okay? But the goal is to sort of be in this area here where it's stable and to have this be as unproblematic as possible.
Aaron, you're a little bit freezing up. So I think the internet might be a little slow on your end there. But if anyone has any questions or wants him to repeat anything there, please just sort of let me know in that text box. I sort of could follow along, so I'm hoping everybody else had an opportunity, but does anyone have anything that they want him to go over again that they missed on that, or repeat it, repeat the whole thing again, or we're good? Okay, I think we're okay, so.
Okay. Am I still freezing or am I okay right now?
You're okay. It kind of goes in and out. It sort of lags a little bit. So, yeah. Deborah did have a question. Why the sudden increase at around a year?
So, yeah, okay, that's a very good question. So what it is that as you start to come out of that spinal shock at that 6-week mark, your body is essentially refiring and rewiring after the injury. And as a part of that, and I'll talk a little bit more about what spasticity is, as a part of that refiring, rewiring, your body is refiguring out all of the nerves and all of the pathways. And that leads to the development of spasticity. And it just on average with people that we see, the greatest recovery after a spinal cord injury is in that first year from a nerve perspective. That first year is where most of that recovery happens, and by that time, your spasticity levels off because of that recovery. Does that answer your question? Yeah? Okay. So let's move on. So as I mentioned, why do people get them? It's that result of that injury to the brain or the spinal cord. Normally, we have these messages that go down from our brain to our spinal cord to our muscles that prevent us from moving and prevent us from unnecessarily moving. As you watch me here, if I keep my hand in this position, I have my hand here, but I'm not thinking to myself, don't move your hand, don't move your hand, don't move your hand. It would be exhausting if I always had to do that. So there are these signals that go down from our brain to our body that are within our subconscious that prevent us from moving. And this happens automatically. When you have a brain injury or a spinal cord injury, those messages get affected. Those messages that stop us from moving get affected. And so if something happens like a stimulus, and I'll have a picture of this in the next slide, but if something happens below our level of lesion, we start to move, we can move, and the brain's message that goes down to say stop that movement doesn't happen anymore because of the injury. And that's why you continue to move, and that's a part of what spasticity is. And I hope that that makes sense to you. It's that lack of that inhibitory message, that stop moving message, which is part of why spasticity exists. So I try this. This can look a little bit confusing, but I'm going to try to explain it to you. And this is just sort of to supplement what I was just saying on the previous slide. So imagine that, somebody is walking along the road and they step on something sharp. So imagine there's a nail or something like that that they step on. There's normally a message that goes up from the leg up here to the spinal cord here, up to the brain that says, I stepped on something sharp, I'm having pain, I need to get off this sharp object. You register that message, right? That you've done something bad to your body. And that's what's normal. There's also a very quick reflex, and that quick reflex is once you stepped on it, you immediately get off it. And that's sort of outside of your control. You have this reflex to remove that stimulus from your body. And that's when you just, like I said, you just take your foot off that sharp object. And you don't necessarily need to have that message go up to your brain for that to happen. There's a reflex that just goes to the spinal cord and back, and it's quite a bit faster when it doesn't go to the brain. Okay? Now, if you can imagine now in this picture, which is essentially the same, but now there's this spinal cord injury here, the message that goes up to the brain can no longer go to the brain. So you step on something sharp, you get the message that goes to the spinal cord, and there's this message that goes back to remove the stimulus and get your foot off that sharp object. But that movement can continue because the message that comes back down from the brain that says, we can relax now doesn't quite happen. So there's some uncontrolled movements of that leg, and that's a part of what spasticity is. Does that make sense? Seemingly, yeah? Okay, good. That's probably going to be the toughest part of this presentation, so hopefully that makes sense, and if you have questions, we can go back to them later. So diagnosing spasticity is really based on a team approach. When I'm working here at GF Strong, seeing people who have spasticity, it's not just up to me as the doctor, it's up to the whole team. So I rely on the allied health, the physiotherapists, the occupational therapists, anybody, nursing, whoever, who's helping to be a part of the team looking after a client. And we need to assess where this tone is and where this spasticity exists. But it's also very important to note that it is different from just regular tone, muscle tone. It's different from rigidity, where something is stuck in a certain position, and it's different from tremor that people have experienced. There are some very common triggers, and these are probably the three biggest triggers for people developing spasticity. So triggers, again, are something like in the example I gave you before, stepping on a tack. that causes this reaction in your body that leads to this uncontrolled movement. These are the three biggest reasons why people have it. One, bladder. So catheter, kinks, urinary tract infections. That's probably the most common reason. The second would be bowel. So things like constipation, not having gone to the bathroom for a long time becomes a big trigger. And then the third one would be skin. So having wounds, ulcers, ingrown toenails, things like that. These are probably the three biggest things that we see. There are more triggers, and I have a slide for that in a moment. But when it comes to these three big things, if somebody's developing new spasticity, we want to check, the things that are most common. So with bladder, checking the catheter, making sure that it's completely straight, no kinks in it, looking for an infection. When it comes to looking at your skin, looking for ulcers, looking for reasons why that could be developing. If there's a new surface, new sheets, new mattress, if there are, causes for infection, a lot of moisture, wetness, and then internal things. So like I've listed here, poor diet, smoking, health conditions like diabetes. These can all be reasons why something could be changed with the skin. And then third, with the bowel, I mentioned the biggest one would be constipation. So making sure that a bowel routine is set in place and that constipation isn't there, all of which can be stimuli to lead to worsening spasticity.
Aaron, just a question from Christina here.
Sure.
She was just saying if you could explain sort of the difference between spasticity and tone and the other things. And
Sure.
She kind of thought that they were all the same there.
Sure, yeah. So they're all quite confusing because they're very similar. The easiest one to differentiate is spasticity and rigidity. So spasticity is this movement that we have here, right? And it's this uncontrolled movement that we see. Rigidity is where something is stuck. It's, if my fingers were stuck in this clenched position here and I cannot get it unclenched, that's rigid, it's rigidity, it's not spasticity. Spasticity is where you have this reflex and you stay like this, but I can eventually get it out. I have to try to tone down that spasticity, but I can stretch it out to some degree. It may not be the full amount and full range of motion, but it's not stuck in a certain position, okay? And another term that's quite like rigidity is contracture. I'm not sure if you've heard that term, but very similar, where something is stuck in that position and you cannot get it out, okay? So that's the easiest one. Tone is a part of spasticity. You have increased tone, which can be a component of spasticity. You can think of it as to be honest, you can think of it as a very similar thing. But spasticity is, again, just that reflex part that I was talking about, where you have this reaction that leads to an increase in your spasticity. Tone is something that we always have. You can have muscle tone, you can have muscle strength, and you can be controlling your arms or controlling your legs to some degree, and that's going to be tone. That's controllable, voluntary tone. Spasticity is involuntary. Does that make sense? So spasticity, you cannot control that movement. It happens on your own. It happens on its own without your control. Tone is something that you have and something that you can control. If you can move your arm, I'm moving my arm, and that's my controlled tone. If I have spasticity and it moves like this, I can't control it. Okay? Tremor is something that some people can think as well is like spasticity because it is movement that you can't control. But tremor is something that usually those triggers that I mentioned it doesn't worsen. Tremor is not a product of that injury to the spinal cord or to the brain. Tremor is something that can just happen for other reasons, but not an injury to the brain or the spinal cord. Okay? So those triggers, if you had a urinary tract infection or if you had bowel issues, that won't necessarily worsen your tremor. That will worsen spasticity. So good question. It's hard to differentiate those things. And a part of it is sort of more, the medical side and doctors differentiating what those things are. But it's helpful to know the difference because then it helps you discover what the cause is and how you can treat it, right? A urinary tract, if you have a urinary tract infection, I think to myself, okay, her movement is worse. Is this spasticity or is this a tremor? I treat the urinary tract infection. Oh, her, the tone has gone down, so it must have been spasticity. But if the tremor continues or the movement continues, maybe it's something like a tremor. Okay, helpful?
Erin, I'm just going to unmute Christina to see if she has anything further. And then I noticed that also Linda had maybe a question as well. So I'll get you in just one sec, Linda. Christina.
I was more curious between tone and spasticity. So just trying to figure out what I have, because sometimes my leg will bounce. And I think that's what you're talking about, the bouncing. Whereas the tone, my leg will fight itself when I try to bend it. Is that tone?
So if you're controlling yourself to move a part of your leg, that is your control of your leg, and that's your muscle tone. Okay? That's your ability to control your tone. If you have that bounce, that may be an element of clonus. That may be something that seems like it's something that you're not controlling, and that's a part of uncontrollable tone that's leading to spasticity. If it's uncontrollable, it's not under your, you're not directing it, it's probably in the realm of spasticity.
Okay, so it sounds like they're almost the same thing, which explains why I've been confused, because they are kind of the same thing, but not.
They are similar, but tone is a little bit more of a generic term because there's controlled tone and uncontrolled tone. So uncontrolled tone, that it's complicated because the technical definition is that it's a velocity-dependent reaction. What that means is that we move your leg and we move you, and there's this increased tone and resistance to that movement. So the difference is that, let me try again, is that with tone, you can control your tone, and you can also have uncontrolled tone. But spasticity is purely uncontrolled.
Okay.
Okay, so umbrella term of tone, underneath that umbrella is spasticity, almost. Does that make sense?
I think so, yes. Thank you so much.
You're welcome.
All right, I am just going to unmute Linda in a sec here. Linda, you're on. Hopefully if we can hear you, but. I don't know if your microphone is there. Let's see. Okay, Linda, I might have to come back to you in a sec. All right, go ahead.
Go ahead. Okay. So I think we were here. So yeah, those are the three most common things. We need to make sure that we assess those to make sure that we can eliminate any obvious cause of spasticity. It may require other things, like you can have further investigations with lab work, x-rays, etc. But certainly those are the most common. But there are lots of other things that can cause increases in spasticity, and I've just listed some of them here. This by no means is an all-inclusive list, but it's a lot of common things that people experience. So other things that are on here that I didn't mention before are things like hemorrhoids, poor positioning in a brace or in a wheelchair, very tight clothing, fractures or dislocations from a fall, poor posture, lots of different things. Essentially, any type of trauma that happens to the body, particularly below the level of lesion, can lead to a worsening of spasticity. And when you remember that graph that I showed you before, if somebody is very stable and all of a sudden there's a change, we need to figure out, we being both the client as well as the medical team behind them, need to figure out, is one of these things going on that's worsening the picture all of a sudden? So a lot of times people ask, like, is it a good thing? Does it mean that there's still some type of connection? Does this mean that I'm going to get better? That's a very common and good question that people ask. And if you remember what I said, it's based on that injury leading to a loss of those inhibitory messages to stop movement. So unfortunately, spasticity does not affect one's prognosis. It doesn't mean that they're in worse shape. It doesn't mean that they're in better shape. And it doesn't mean that it's not a sign that they're going to get better in regards to their function, okay? But certainly it is something that is common after a spinal cord injury, and it is movement that people see and they're hopeful about it. And as I mentioned, it is generally a warning or an indicator that something is happening in the body because of that loss of that inhibitory message. So there are a number of things that can happen following spasticity that we would call complications. And this is sort of a list of some of them. The biggest one is really that the biggest one is actually probably the second one. It can cause discomfort and pain. But equally important is that it can interfere with function. A lot of times people get an increase in spasticity. They find that, they can't get themselves into their bracing. They can't get themselves into their wheelchair. It's affecting their care when it comes to hygiene, showers, putting on their clothes, etc. It can also lead to, this is a terrible word, but disfigurement. But if somebody has a very strong spastic muscle, then their arm, their leg is in a position that is uncomfortable and looks aesthetically unpleasing, and so that can be challenging. It can be a risk of developing ulcers. As I mentioned, it can interfere with care. And eventually with spasticity, if you have this increased uncontrolled muscle tone that isn't treated, it can lead to contracture, which is what I was saying before. It's that rigidity stays stuck in a position because we have left it untreated for a long time. So that's certainly one reason why we want to treat it, which I'll talk about later in the presentation. So I've said a lot that makes it sound like it's all doom and gloom, but it's not. Spasticity is not always a bad thing. And a lot of people actually use that tone, that uncontrolled tone, to help with their function. So some of the benefits of spasticity I've got labeled here. One, it can help people walk. It can help people stand. It can help people transfer. They use some of that tone that's in their legs that they can't control to support themselves as they do that function. It can also help to maintain the muscle bulk, which is the size of the muscle. In somebody who doesn't have spasticity, those muscles are no longer contracting and relaxing. And because of that, they start to get smaller. And you may have seen that in yourselves or in other people that you know, where the muscles just look very small. And that's in part because there's no constant contraction and relaxation. When you have spasticity, that's happening all the time, so the muscles kind of stay at a normal size. Again, with the third one here, because of that movement of the muscles, the blood flow is aided because of that contraction and relaxation. So blood clotting issues are decreased. So things like DVTs, which are deep vein thromboses, are generally reduced in people who have spasticity. It can also help to prevent or delay the breakdown of bone, which is osteoporosis, because it is still sort of movement in your limbs. So spasticity, as I've kind of hinted at, the big question is it problematic or is it non-problematic? If it's non-problematic, the example here in this image is just, it doesn't cause pain, doesn't cause skin breakdown. If it's non-problematic, then when it comes to thinking about whether or not we need to do something about it, we probably don't if it's not bothering you. The problematic side is where we really need to help you as a client to help manage those problem issues. And when it comes to treatment, which we'll get into, it is a bit of a trial and error. We need to figure out what's going to work best for you. So in this picture, I can just move this over. So this is just sort of a picture that kind of documents some of the areas where spasticity can be a bit problematic. So first of all, with body structure, it can lead to contractures, as I mentioned, where it's that rigid joint because we're not able to alleviate this spasticity. It can lead to skin breakdown, causing wounds, ulcers, and it can lead to pain. And those are all very big problems. It can affect your function, both active and passive function. So active function is you doing something that you want, you transferring yourself into a chair, you trying to walk. Passive function is when, if you have a part of your care team, or you are with a therapist or somebody who's trying to help you do something and your function is limited because of the spasticity. Quality of life, one of the biggest things here, where you're unable to participate in a lot of the things that bring you joy and a lot of things that are a huge part of what make you you. So being able to do sports, recreational activities, being able to work, being able to volunteer, that's all important. And then another one is cosmesis. So under here is the perception of yourself. Spasticity can be, it can be a problem just in regards to being comfortable with how a joint or how a body part looks if you're undergoing spasticity and it's affecting you. And certainly I know a lot of clients that I've worked with, just being with people and having an episode of spasticity can be troubling for them to be in front of other people and experiencing that. So when it comes to these issues, and these are certainly not all the issues, we want to do our best to be able to get the spasticity under control so that you can continue to have good quality of life, good function, and all of that. So, as I mentioned, treatment is really based on whether or not there's a problem. So when there's a problem, then we have to figure out what are the goals. And that's really the most important piece of treatment. So it's always based on goals. The first thing is I like to think is technical. So that's like range of motion. You want to be able to get your wrist to be able to be straight. That's sort of this technical goal, to work on that range of motion. The next thing would be functional. So being able to do your activities of daily living to get your pain reduced. The next thing would be caregiver goals. If you are somebody that requires some assistance with a part of your care, and maybe the spasticity becomes a problem, again, at the example of maybe hygiene, taking a shower, having a goal of reducing some of your spasticity to help the caregiver is important. And then lastly, for me, it's often preventative. So we want to prevent that contracture from developing. We want to prevent an ulcer from developing. So these are sort of the big categories of what I look for when I speak to clients about spasticity, to figure out how can we best help with the problems that exist because of spasticity. So these are some of the questions that I like to ask when I'm talking to figure out the goals. So does the spasticity significantly affect function? So is it walking? Is it transfers? Is it dressing? Is it doing catheters? Does the spasticity lead to pain or discomfort when you're just doing your regular activities, or when you're trying to put on a brace or footwear, something like that? And is there a risk of or presence of those complications? So this is sort of the same thing as the last slide, but these are the questions that I would ask, or you can ask yourself in regards to trying to figure out whether spasticity is a problem and whether it should be treated. So this next slide is going to end up being very busy, but I'm going to go down line by line because this is sort of the general approach in regards to how we go about treating spasticity. And it's a wide scale, starting with a lot of non-drug, non-surgery treatment all the way to the other end, which would be surgery. So the first thing that we like to do, the most important thing, is education. So, when I'm working with my clients, if I can arm somebody with the knowledge of what is going on and why it's important to think about, I think that's the most important tool dealing with any issue in healthcare, in spinal cord injury, whatever it is. So education is important. So making sure that, you do daily checks with your skin, you have a bowel bladder routine, proper positioning, knowing what spasticity is, knowing how to realize I need to get somebody to assess me to figure it out. That's the most important piece. And this talk is just a part of that piece of the puzzle, right? To try to hopefully get you to understand a little bit better about what some of the triggers are and how and when you should get some help. The second thing is to avoid some of those noxious stimuli, to avoid those things that can lead to spasticity, those triggers that I mentioned before. So infections, urinary tract infections, pain, ulcers, skin issues, ingrown toenails, etc. Recognizing that those can exist. The third thing is just stretching and range of motion. So continuing, whether you're doing it by yourself, doing it with a friend or family member, or a part of your care team, ensuring that you try to stretch all of your muscles and joints to prevent spasticity. The next thing would be sort of starting to utilize some of the healthcare team. A lot of this is with physiotherapists as well as occupational therapists. Sometimes people have splinting done to try to improve or maintain range. Serial casting is similar, trying to make sure that we get a certain joint into the best position, and we may need to have new casts to further extend range. And different modalities, so different treatments like functional electrical stimulation, vibration, relaxation techniques. Again, all various options that don't have a lot of, it's not a surgery, it's not medication, it's something that can be done externally to you that has very few side effects or problems. And this is sort of combined with that. So other allied health, working with the physiotherapist and occupational therapist in order to come up with some of those strategies. And other things can include like acupuncture and things that some people have said that have been helpful. Then you go down the route of topical medication. So there can be different creams and things like that. And this is venturing into the world of seeing your physician who can help. Then we go on to oral medications. I've listed here the 4 main medications that are used to treat spasticity. Some of you may have seen some of them, heard some of them, or even maybe using some of them. If you have specific questions about them, I can go, you can ask them later, but I haven't gone into too much detail about the differences in these medications. But certainly, this is usually an avenue that we go down for people who have problematic spasticity. Then we go on to local interventions. And what I mean by that is that those medications you take orally, it goes throughout your whole body because it spreads through your bloodstream, so it treats your entire body. But sometimes people don't have spasticity that affects their entire body. It just affects a certain part, whether it's the hand, the elbow, the leg, whatever it is. And so because of that, we can do local interventions, which is essentially another word for injection. And I'm not sure if you've heard of some of these things. One thing that we use is botulinum toxin, also known as Botox. Something else that we use is phenol. 2 different injections that are used at that local area, the specific targeted muscle, in order to try to reduce that spasticity. The last thing on this list is surgical procedures. So there's a whole slew of different things. I've listed a number of them, including, my phone is ringing. Hang on for 1 second. Oh, they hung up. Okay. Including intrathecal baclofen, tendon transfers, tendon lengthening, electrical stimulation, nerve resections, otherwise known as rhizotomies. There's lots of different things. And this is a stepwise process. You start off at the top and you work your way down to the bottom. So what I mean by that is that all of these surgical procedures are really a part of the last line of therapy when all of the things above have not been effective to treat the problems. So Botox is a big thing that people use. And a lot of times people think of Botox and this is what they think of. They think of cosmetic reasons. Wrinkle lines, celebrities use it all the time. But this is what I think of with the injections. So this is that localized treatment that I was talking about. That middle picture here is working on leg muscles. And then this picture here is working on, upper extremity muscles. We can inject certain muscles if those are specific areas causing problems. I put this slide in here because this is something that I do. I'm one of 3 doctors in BC that is a part of assessing people for intrathecal baclofen. This is one of the surgical procedures that is an option down the line if things don't work. And baclofen, if you recall, is one of the oral medications that some people use. This is a pump that is placed inside the body, and it delivers this medication directly into the spinal cord. Again, later down the line, if you have questions about it, I can chat with you about it later, but certainly just an example of one of the surgical procedures that is done here in this province. So what to do? After all that I've said, whatever you already knew about spasticity, if you've learned something new about it today, hopefully what you take away is that you have an idea of what some of the triggers are, you have an idea of what it is, and when you put those two things together, you recognize that you're having a change that needs to be addressed. So having a family doctor who you can regularly see, who knows what you're normally like, who can then say, you're right, something is different, something is new, and we need to figure out a cause. If you know what the cause is, you have a urinary tract infection, you treat that infection and it goes away, your spasticity goes back to your normal baseline, great. But when that doesn't work, you haven't figured out what's going on, seeing a physiatrist, somebody like myself, is a great opportunity to help with diagnosing the spasticity, to help with diagnosing and figure out what could be causing it, what could be making it worse. And then, of course, how can we manage this better? And then, of course, we can follow up as we need to help guide that management moving forward. The issue is really just access to us. Physiatry is a little bit of a smaller field in Canada. It's a little bit of a newer medical specialty. So there aren't a lot of us around. And if you're in the lower mainland, Vancouver Island, accessibility is generally quite high. Outside of that area, it's a little bit tougher. We have some outreach that goes up into Prince George. We have a number of physiatrists, but not as many in the lower mainland, up in the Okanagan region, Kelowna, Kamloops. And we're trying to start to develop more and more availability to some of the other, some other sites in BC, but certainly it's challenging, and I'm not going to lie about that piece. But if it is an urgent concern, something that really needs assessment, your family doctor will be able to access communicating with us, and we can arrange as best as we can to help out, whether that's in person with transportation or even some type of teleconference with you or your family doctor or a phone conversation, just so that we can do what we can to help. And what's the future of spasticity? You know, medical research is always ongoing, trying to improve care, trying to improve treatment. These are four very general big categories. And I would say that a lot of the research, and I've done some of this research, is really into image guidance and injection techniques for some of those, some of the things like the Botox injections that I was chatting about. Oftentimes we're trying to, that's a big treatment management strategy that is used, and we're trying to make that better and more effective to help people with their local spasticity. So there's a lot of research into how can we make this management strategy even better and more effective. So that's that. Yeah, so that's sort of the end of what I had prepared for you guys. And I guess we can open it up to see if there are any specific questions.
Awesome. Thank you, Aaron. Can you stop sharing your screen so then we can see all the beautiful faces? Okay. What I will do at this point is I'll probably just like unmute each person one by one. And then if you have questions, please just ask. And I'm just going to go by who's on my screen here. So I'm going to start with Christina, because you're up first. So go ahead if you have any questions for Aaron.
I'm still kind of on that whole tone thing and trying to figure out the difference, but I wonder if maybe my questions might be better suited to my specific physiatrist or GP. Like, for example, I have the spot in my back that's been there since my spinal cord injury, and it's always been evil and it's never let go. So I almost wonder if that actually might be some of that rigidity that you were talking about, or a spastic tone thing. And it causes me a lot of pain.
A lot of pain. Yeah, I mean, when it comes to tone that is not in, like, your hand, your elbow, your knees, your hips, all of your joints, it's easy to see, because that's an area that when you see your doctor, they can move that area, or you can move that area, and you can sort of get an appreciation for how much is controlled and not controlled. When it's an area that's not as easily able to be moved, like a back muscle, an abdominal muscle, it's very challenging to put a label on what that is. You can appreciate that this that could, this could probably be spasticity. But your back, I get it. It's really hard to say what that is. Excuse me. I would say that in that specific case, I would see your family doctor, your physiatrist about that further to see if they can put a label on it. It's hard for me to be able to tell you what that is in this context. But it could be a lot of things. It could be spastic muscle. It could be neuropathic pain. It could be something that's there. But certainly, I can appreciate the confusion in that regard for you. And I apologize that I can't tell you without actually assessing you on that.
That's fine. I understand. Thank you.
Yeah.
I'm good.
All right. Next up on my list is Deborah.
Yeah, I think thinking about my husband's spasticity, he doesn't medicate himself at all. It's probably more of a problem for me than it is for him, but his whole diaphragm is affected. Like it takes his breath away and he can't breathe for a period of time until it relaxes. What would you think potentially could be triggering something like that affects the diaphragm?
Is that the only part of his body that he has?
Oh, no, everything else does too.
Everything else as well. Okay. How often does that happen?
Frequently. If he shifts position quite often.
Yeah. So
definitely in bed when he gets in and out of bed.
Yeah, so and you hit it on the nail right there. Unfortunately, with spasticity, but commonly, changes in position trigger spasticity. How many people I see on my floor here, the spinal unit floor, where the first thing in the morning when they're trying to get out of bed and they're, the nurses are helping them move a certain part, and then all of a sudden they have that triggering spasticity. I guess the issue is, with those people, I would say if it's a problem for them, we try to manage it. Use various methods. If it lasts for a few seconds to a few minutes and it's tolerable, then they usually choose to say, I don't want to be treated because I don't want to have side effects, medications, etc. And so it's a part of the discussion that you and your husband would have with your family doctor and or a physiatrist. If it's a problem and it's affecting breathing to the point where you're worried about his actual ability to breathe and it's long-standing, he's turning blue, something like that, that should be treated,
Sure.
And there are considerations to be made at that point. But if it's like some of the people that I see, it lasts for a few seconds, lasts for a few minutes, otherwise okay, I can appreciate why he isn't being treated for it. It's unfortunate that it's affecting his breathing. Like that's a bad muscle to have it affect. But that's sort of in the element of when I presented the problematic versus non-problematic spasticity. I think she froze, or there you go.
No, that's good. He sees it as a good thing. So he sees it as a positive that he's got the spasticity and that he's got really good muscle tone and has never had any skin issues in 33 years now. So
those are some of the positives, right? And I know that it's fortunate that he hasn't, right? But like I said, it's not always a bad thing. It's not always bad.
More distressing for me, I think, than anything.
Yeah, no, for sure. But as long as it's not affecting his function, it's not giving him debilitating pain, and he, it doesn't limit what he's doing, a little bit of spasticity that is manageable is okay.
Yeah. Thank you.
Yeah, you're welcome.
All right, I think I'm gonna mute Deborah there. We got Jolene is on the phone. Jolene, can we hear you?
Yes. Can you hear me?
We can. Yeah.
Hello. Oh, thank you so much, Terry. It's wonderful to be able to see you.
You too.
So
well, I can't see you, but hear your voice.
Okay. So I have a question. It's very related to the last one. I have spasticity that affects my respiratory muscles, and it affects me all the time, every single minute of the day, and it affects my breathing. and so I have to use oxygen because of the painful spasms. So are there options to help people like me?
Jolene, if you are comfortable sharing in front of everybody, like, are you using any treatment right now?
No, nothing.
Nothing at all. Okay. Do you see a family doctor or have a physiatrist for this?
No, I have a family doctor, but he hasn't been able to help me.
Okay.
I use baclofen because I have a neurogenic bladder, but it doesn't do anything to help with the spasms of my respiratory muscles.
Nothing at all. Have you?
Nothing.
Have you tried increasing the dose and things like that with that medication or other things?
They increased it up to the maximum and it didn't do anything. Even starting the baclofen didn't do anything.
Okay, all right. And that's the only medication that you've tried?
Neurontin helps a little bit, much better than baclofen, but nothing. It stops the spasms that affect my breathing.
So when it's affecting your breathing to the extent that it is for you, I would say that certainly that is problematic, because you don't want your breathing, because that's something that happens, every few seconds of the day, right? So that's a problem. I would say that there are a number of different agents that we can try and add on to your therapy. Like I said at the very beginning, with spasticity, it's challenging because it's a trial and error basis. Some medications work really well for some people and some don't work well for those people. So if you've only tried baclofen thus far, there are a number of agents that we can try just to see if those work. And we'd also want to, before that, make sure that there isn't anything going on in your life that is a constant trigger for you. I don't know if your family doctor has, maintained your health in the things like renal health, renal care, make sure you don't have things like stones, chronic infections in your bladder. All of those things can lead to a continued bubbling stimulus that causes worsened spasticity. Assuming that's all okay, then I revert back to what I said, which was there are a number of other agents we can try. And then further down the line as well, I know that some of those surgical procedures, like the intrathecal baclofen, has been helpful in some people, not necessarily with the breathing, but with some of the abdominal muscles and things like that, which is around the diaphragm. So I imagine that it would be still possible to help with that muscle. Sorry, I'm rambling a bit, but there are still options for you, Jolene. I would say your family doctor would probably benefit from having a chat with some of us or something like that to help guide your care. But there are still options for you.
That's very wonderful to hear. The major triggers to it happening are talking. Mm-hmm. So as soon as I talk, it increases the spasms. Taking a deep breath, anytime I try that, that always makes the spasms worse, and then it feels like a piano wire cutting. Mm-hmm. So the only thing that helps, they bought me a very expensive AVAPS BiPAP machine, and that helps push through. So I have to use that several times during the day when it gets very bad, and because I can't breathe at all. Mm-hmm. And then I get chest pain. I have heart failure from this because I don't get enough oxygen. Mm-hmm. So I have to use oxygen. But it would be wonderful to be able to breathe. It is. I don't care about not being able to walk very well. I don't care about any of the rest. But breathing. Mm-hmm.
That's an essential.
Number one. So I will ask my family doctor to send a referral. Should I? To just
where are you? Can I ask?
I live in Creston, a long ways away.
Okay. Yeah, I would say try to get your family doctor to speak to get in touch with a physiatrist. They should be able to look us up easily, and we will have to figure out how we can best help. Whether, again, it's a phone conversation would be easy to do. You know what I mean? Just to be able to touch base, and that would be an easy start. We could always progress.
Yes, perfect.
On that, right? So yeah.
Perfect.
Okay.
Thank you so much.
You're welcome.
Bye.
Terry, we can't hear you if you're talking. I can't hear anything.
Thanks.
Yeah.
I muted myself. Rick, do you have anything?
Sure, I'll ask you a couple questions and sort of a couple comments. I'm about 11 years post-injury, C5-6, and I actually see the doctors regularly at GF Strong. I was there on Monday to get Botox shots and phenol. Now, my spasms, when I get moved out of bed in the morning, my legs kick out real bad, etc. And in the shower, my knees lock up right so tight together that they can't wash me properly. That's what they use the phenol shots for, is to loosen that up. But like, I have lost a great deal of muscle tone because I've been on gabapentin almost since day one. And the only thing that I found that is now I'm decreasing my baclofen is by using some marijuana product. What's your opinion on that? I started on the synthetic marijuana recommended by the physiatrist from GS Strong, but its availability was just so inconsistent that I went with the prescribed medical oils.
Great question. And I actually had it in one of my notes, but I forgot to mention it. Cannabis, cannabinoids, that whole group of medications, there's a lot of evidence that it can be, or I should say a lot, there is evidence to say that it can be helpful in treating spasticity, in treating nerve pain, all these related spinal cord injury issues. So you're not by any means the first person to tell me that that's helpful, and I know that it is. I am somebody who is all for using something that helps to treat your pain, treat your spasticity, treat your nerve pain. So the problem with cannabis, cannabinoids, more so been getting the same dose of it.
Right. That's why I went through through a pharmacist and prescribed as a company called Canamed that's supposed to be fairly recognized in getting the oil that way rather than.
Exactly. So that's been one of the most challenging parts, right? When you walk into one of the many stores in Vancouver that have cannabis, you have no idea what you're getting from them. And that's where the problem lies. There are commercially available pharmaceutical products that are available as well.
I was on Nabilone.
Nabilone, yeah. Was that helpful?
But it worked almost as good as the real or the natural stuff, but its availability, they keep running out of it because it's so popular. And
it's currently not available.
And then all of a sudden they take it away from you.
Exactly. It's really unfortunate. It's that part. I get it
3 times.
Exactly.
So that's why I went to the cannabis store.
Yeah. No, I appreciate that. I have other patients who are doing the same thing, and I'm fully on board of that. I wish that the Nabilone and those products could be continuously available, because at least with those, you know what you're getting. You're getting the dose. It's a regulated product.
Right.
If it were completely regulated, it would have been on my slide for sure.
Right.
But thank you for the question.
I expect that to happen in a few years, but yeah.
Yeah. It's a work.
Check your interest in that, and that it's working for me. I just see the question is I'm using CBD during the day, which helps medium THC at night and sleeping. I used to sleep 3 hours a night. Now I get 6 or 8 hours a night. With the THC oil.
Primarily speaking, the effective component of the cannabis is more so the CBD. The THC has some side effects that are kind of more undesirable from a medical standpoint.
Right. That's why I only use it at night. It helps us sleep, but the CBD does medium results during the day.
Yeah.
All right. Rick, there's a question here from Christina. Do you have to take a lot of CBD and it helps with your spasticity as well? Question mark.
It helps. It reduces it. It doesn't take it away. I've gone from 3,000 milligrams of gabapentin down to, I think, 2,100 by taking the CBD during the day, and I take 2.5 milliliters like 8:30 in the morning and 3:30 in the afternoon. and it keeps me, my legs always feel a little tense, but they're not kicking all over the place, except for during transfers. And it's about the same. And I'm going to try to slowly decrease the gabapentin.
Awesome, thank you. Okay, next I have on my list, oh, hold on. There was another question from Christina. And this is the product you're saying you're having trouble getting a consistent product.
Or it was a good quality. It's a synthetic marijuana called Navalene or Navalone. Navalone. And it worked almost as good as the actual marijuana, but the actual marijuana does work a little bit better than it.
Great.
But
Cool.
it's just
Navalone is a commercially available product made by a pharmaceutical company. And it's regulated, it's standardized just as you would take any other medication. You get it from a pharmacy. The problem is that it is currently and has in the past been short from the manufacturer, which means that they can't produce it quickly enough in order to sustain the need for it. So right now I have a number of patients who are on it, but I can't give it to them because it's not available.
And what about the Sativex?
So Sativex is another medication that's just that's similar. It's a commercially available product, but it's a nasal spray version of the cannabis. Equally good. The problem with that medication is purely cost. It's very expensive, and it is not generally covered. Navalone is quite a bit cheaper.
Gotcha. Thank you. All right. We've got Roderick. I don't see your face, but if you'd like, oh, he's muted himself, so he is good. Maureen, do you have any questions?
I'm just concerned about. I live in Williams Lake, and I don't get a chance to see a urologist or people specialize in spinal cord injury very often. And my family doctor is pretty young and really nice, but I don't think he quite understands the situation. Like even when I get a bladder infection and I know it is UTI, he just sort of goes, well, he just doesn't quite know. He kind of takes it from me instead of, even though the not just the symptoms are there, but it's throughout the tests are there. Yeah. And so that's my question is, I have seen someone in Vancouver, but it's pretty hard for me to travel to Vancouver to see someone. And I don't know of any other. I haven't had any testing done on my bladder for probably 3 years now, and I'm 3 years, and I'm 4 years in the chair. I'm 4 years in spinal cord injured. Okay. So I just wondered how to kind of. I've talked to him about referring me to someone, but maybe in Kamloops or Prince George, but he just hasn't done it yet.
Sure.
I'm not sure how to approach that. Great
question. And, I touched on it before. One of the biggest problems, everything I'm saying is all fine and dandy except for access, right? Being able to, like I said, if you were in Vancouver, we could arrange to see you very quickly. But you're in Williams Lake, which makes it a little bit more issue. And I can appreciate the challenges that your family doctor has, because spinal cord injury is a niche field. It's incredibly important to you, and it's incredibly important to me, but our numbers are small, right? And because of that, I went through medical school. I know how much training there is in medical school when it comes to spinal cord injury, and I will tell you it's next to none. You really interest go into this field in order to learn about it, and then you get to my stage where you've finished all of your training, and that's when you have that specialized knowledge. So I can appreciate your doctor not really understanding, not really knowing certain urgency and that you have to live and deal with every day. How to improve that access? So one thing already told you is that one, education is most important. So it seems like you have, you know a lot. You know that you have a urinary tract infection, and you're doing what you think is best, which is the best. Going to your family doctor. What do you do now? So, I don't know if it's just going back in to remind him or what it is, but having that referral made is really important, and letting him know that, if I like you, you're great, but if if you need some help, or if we need some help to get a specialist involved to further my care, let's go ahead and do that. So making the referral down to Kelowna, Kamloops, Prince George is one step in that direction, or even down to Vancouver. Like I said, if there's a referral from him or her to say, hey, is it possible for us to have a telephone conference about this patient that I have who is this old injury? I'd love your input into how I can better help manage this person. And then if it were me speaking to your family doctor, I would say, these bladder issues, renal ultrasound, all of your urology follow-up needs to happen on a yearly basis, particularly in the first 5 years. That's important. It is a lot easier probably coming from me than it is from you, because I know, the healthcare system a little bit more and how we can navigate that, and I can help him or her do that. So, you are going to be your biggest advocate in your health. And so going to say to your family doctor, hey, I think that there are some areas that we can improve my health post-spinal cord injury, and maybe it would be a good idea to, you attended this session, and the doctors of Vancouver are saying they're available to be able to help answer questions and stuff like that. Maybe the push that your family doctor needs in order to make that call, or that, get in touch with us.
Yeah. Thank you. I appreciate that, because I'm relatively new at this too. So, yeah.
No.
And it's kind of nice to be able to talk to somebody who's more experienced, right?
Right. And, I guarantee that, in another couple of years, or maybe even 10 years, you are going to be super experienced with it. You're going to know, you live this in day out. And like I said, you're going to be your biggest advocate, which is great. You need to be your biggest advocate. But you need to have the support of your family doctor and specialists from afar to be able to help you with that. Your family doctor probably doesn't know how important it is to have urology follow-up, particularly in the first 5 years, because that was the leading cause of complications in spinal cord injury 20 years ago, was kidney damage, kidney failure. That's why you want to get that regular checkup, right? And your family doctor is not going to know that, because he or she doesn't know spinal cord injuries well, right? So getting that information from us, from Kamloops, from wherever, is going to be a key piece of your healthcare.
Right. Yeah. I kind of I thought so. I thought I should be having one every year, and I just don't. I guess I'm not pushing enough. I just need to get him to refer me to someone.
Yeah. Be friendly about it, but certainly, in a nice way. Understandably, his knowledge of spinal cord injuries isn't as high, because he or she probably doesn't have a lot of patients who have spinal cord injuries, right? So it's
Absolutely.
hard. Yeah, and it's very hard to manage that. So they need to know where some of their limitations lie and be able to seek out advice. And we are very easily approachable, I think, to be able to get advice from. I will happily take a phone call from somebody, a family physician out there, if it means helping somebody's care. And I'm sure that my entire group would feel the same, speaking on behalf of them.
Thank you.
Yeah.
Thank you very much.
You're welcome.
Thanks, Maureen. All right, let's move on down the list here. Diane, do you have anything to ask or any questions?
I'm finding it very interesting. My injury was 32 years ago, L1, and I'm an incomplete spinal cord person. The problems I have are UTIs, but I do have a good urologist. But my bowel is a continual problem, and as I get older, it just gets worse and worse. And I wonder if there is anything that can be done to help this.
So that's a good question and a very important question, because usually after people have spinal cord injuries, bowel and bladder complications are probably the number one thing that people deal with after that they find to be problematic. Are there things that can be done to help you? Challenging question to answer, because I don't know what's been tried. I don't know what's been done. I don't know your specific case, but a very general answer would be yes. I've dealt with a lot of people in the acute setting as well as in the chronic setting, and I would hope that you have not already tried every single thing possible out there. The issue is really just being able to have the team behind you to help you go through those trials. So again, your family doctor is your quarterback. Your family doctor is a person who will help you as best as they can. And when they are realizing their limitations or reaching a point where everything that they know hasn't been helpful, then they need to go and seek out help from somebody else. So whether that's speaking to a physiatrist, speaking to a gastroenterologist, whoever that is, to help you, because I hear exactly what you're saying, and it is a very normal thing. Whereas you say, the older you get, sometimes things change, right? And you need to get help with that, because that can certainly worsen your spasticity, and that can certainly just worsen your overall health care if your bowels are not, are not regular and you don't have that routine. So speaking to your family doctor and really making sure that if they need some assistance, to seek it, right? But there are a lot of options to help. That, yeah, again, I hope that you haven't exhausted.
I hope so too. I have had colon cancer, and I think there are probably more things that out there that would help. Mm-hmm. So I will explore that further.
Yeah, I would speak to your family doctor again and just, and see what they can do in regards to helping you themselves. And then if not, getting some outside support from a specialist, because again, it's a real problem for somebody with a spinal cord injury.
Okay. Thank you very much.
You're welcome.
Thank you, Diane. Always nice to see you. All right, so who do we have here? Linda, can we hear you now, Linda? Oh, I still can't hear you. I can see your mouth moving. Huh. It's weird. Okay, I'm gonna can you type in, Linda, the text box? I'm gonna try Patty. Patty, do you have anything to ask Patty at all?
Me?
Yes.
Yeah. No, I don't have a spinal cord injury. I have multiple sclerosis, but I sure get spasms. And I recently went to a new doctor at the MS clinic in Victoria, and she prescribed, I'm not sure that I'll get the name right, but pramapraxine.
Yep.
It's a medication used for Parkinson's disease. And this doctor, I don't know whether she had read research about it or she just got the idea that it might work. And it was magic, wonderful. And so I would just like to share that with everybody, see if they might be able to try that. No, that's really...
No, sorry, finish, sorry.
Yeah, I have no side effects. I take far less than she prescribed, because it knocked me out. Like I could hardly open my eyes all day. But so I take a very small amount of it in the morning and at night. And I just did have some spasms for a while, just a few minutes ago, but it's gone. And if I have to, I can take more of that medication in the daytime. But so I wonder if the doctor knows about using that.
So it's a very common medication that's used in multiple sclerosis.
What's it called again? Sorry, what was it called?
Pramipexole.
Okay.
Yeah, again, it's a very common drug that I see used in patients that I've seen with multiple sclerosis. It's not a common medication that has been used, and it hasn't been studied in spasticity specifically. So it's great. I'm so glad that it's been helpful for you to help with not only your multiple sclerosis but also with your spasm. But it's not something that has been studied enough to be able to use outside of that as of right now. But good to know.
I never heard of it. Nobody else I'd ever seen had ever heard of it or ever tried. Like, I've had spasms for decades. Even before I got MS, I think I had them. So they were, and sometimes they were so bad that I just read on your list there that it actually, it didn't break my bone in my ankle, but it pulled the muscle away from the bone.
Mm-hmm.
So it was that bad, and that nobody ever heard of this medication. So I think it should be, there should be more knowledge about it.
Yeah, we will. I'll make it a personal learning objective just to read a little bit more about its use in spasticity. But I can, historically speaking, right now, our group here has not been using it for spasticity, but it is used commonly here in Vancouver for multiple sclerosis.
Well, that's better. I better let the other MS doctors know about it because nobody else knew. But anyway, that's it. Thank you. I hope I could be helpful to somebody.
Thank you.
Okay, thanks, doctor.
You're muted, Terry.
Thank you, Aaron. Linda, I'm going to try you again. I still can't hear you, Linda. I don't know what's going on. All right. I am going to try. I see you on mute. Try again. No. I'm going to try Orlando. Would you like anything to say, Orlando?
Yes. This is for myself. I've been injured for the past over 5 years now. And I noticed lately, in the past months or so, that on my skin, I got all this like breaking out. My family doctor tried all these blood tests and everything, did not see any virus or something like that. But I don't know if this is a rash or an acne or psoriasis. It's like all over the place now. So I don't know if that's related to spasticity or so, because I'm trying to do cure just for myself, like, putting all these lotions, everything.
It's tough to say because I can't see you, so I don't know. But certainly, usually spasticity doesn't lead to rashes and things like that. The spasticity that can lead to wounds that we're worried about is because you can imagine, for instance, say your back is always resting on either your wheelchair or resting on your bed, and you can imagine if you're having spasticity of your back, you're constantly rubbing against your wheelchair or rubbing against your bed, and that can lead to skin breakdown, and that can lead to a wound. And in the case of somebody who has a spinal cord injury, if that wound develops below their level of spinal cord injury, they might not experience the pain. They might not know that it exists. And that's why that's a bad thing, because if you have a wound that you don't even know about, it can get worse, it can get infected, and that leads to a trigger of spasticity. But the spasticity itself doesn't usually, I've never seen it cause a rash or a blister or something, unless it's over an area that has friction against, a chair or a bed or something like that.
Okay, thank you.
You're muted, Terry.
I'm so bad. Sorry.
It's okay.
John's watching the soccer game, so I'm trying to like unmute and so no one hears what's happening, just in case anyone wants to know. All right. So Roderick, you have to unmute. Oh, there we go. You're on.
Right. Am I unmuted? Great.
You are.
I'm tempted to ask about the soccer game, but I won't. Don't know if you caught my note there, Dr. Chan.
Yeah.
Yeah, so I'm a physician myself. I'm C4 incomplete, and we've tried a bunch of different things with my spasticity, and we're still working on it. So I'm not trying to squeeze in a consult from you here. It's you know, I guess overall is just trying to, at some point, if everybody has exhausted their questions, then I wouldn't mind picking your brains at a bit of a deeper level on spasticity. But interesting, so I take pramipexole, but that's because I had even prior to my injury, I had a pre-existing periodic limb movement, restless leg kind of thing, that when we toss the spasticity on top of it, it's like restless leg on steroids. And we threw every antispasmodic at it and still just completely destroyed my nights until we recognized that we could just try treating it as the restless leg. So, and it's been extremely effective.
Sure, good to know.
It's a dopamine agonist, commonly used for treating Parkinson's. And so, yeah, I mean, it really raises the question of, where does dopamine fit into the whole picture of modulation of pain and spasticity? Because, I mean, what isn't affected by dopamine?
Yeah, that's true. To be honest, I can't answer that question in the sense, like, I don't know. Typically speaking, dopamine is not a part of the spasticity pathway that we necessarily see from a pathophysiologic standpoint. It's not a part of how we have treated it in the past. So it's helpful to know that this is something that's been used sort of, if you can call it, off-label, not a typical medication for spasticity, and that's been helpful. But I don't know. In all the research that I've done on spasticity in the past, dopamine has never been a part of that treatment process. So I'm happy to know it's been helpful, but I can't answer that question. I apologize.
Yeah, no, I guess that part wasn't really so much the question part. That was my comment on it, because maybe it sounds, I didn't catch the name. It was Catherine, was it?
Or Patty, maybe?
Sorry, the lady that was talking about the pramipexole for MS. But it sounded to her as if any of the MS people that she's talked to haven't encountered that as well. And so I'm just wondering if it is something that is starting to, people are wondering if dopamine might actually be linked into the spasticity thing.
Absolutely. That's a great question. And, I definitely will look into this afterwards. You guys are the first people. That's helpful.
Got yourself a research thesis there.
Yeah, there you go.
But yeah, I'll see if anybody else has any more questions here before I get into any sort of my deeper questions on spasticity.
Awesome. Sounds good, Roderick. I don't think we have too many people left. I don't know if Charles. Charles, did you have a question? I'm not sure if we can hear you. I don't think we can hear Charles. Well, I kind of have a question, actually. And if anybody has anything else they want to ask, if you could just sort of type in, unmute me into that text box if you can, that'd be awesome. Maybe I'll try Linda one more time here, because Linda, can we hear you yet? I don't know, something's not working on your end there. weirdly. But so my question is, this is sort of what I've seen. I play wheelchair rugby, and I've noticed that a lot of athletes get clonus when they're playing. So the question that I had is, what if you get it just when you're doing certain activities, but you want to do those certain activities? Can you take a pill that will just last for a little period of time, or while you're doing that activity, to sort of relax the muscles a little bit?
Yeah, unfortunately, there aren't any what we call PRN medications, so as needed medications to treat spasticity. Yeah, that's the short of it. Unfortunately, not.
Okay.
Try different measures. I wish that we could, but there's nothing in the current treatment regime for that.
Okay. And then the other question that I had with the Botox. So one thing, like, I know that people seem to be a little bit nervous sometimes about trying Botox because, I mean, there have been some negative results as well people can experience. So my understanding is that sometimes you can get whatever that local anesthetic is that is just temporary to test the muscle group beforehand, and then it's very a short time, lidocaine or something like that.
Yeah.
Is that what you guys do regularly, or?
For Botox, botulinum toxin, usually we don't couple that with the lidocaine test because botulinum toxin, the risks of it are fairly low. There is, bleeding, bruising, infection at the site of the injection, and it is temporary. Although it lasts about 3 months, that is still temporary, which is good. Lidocaine we will typically use in cases where we're doing more complicated procedures, potentially a nerve block or phenol or something like that, where it is temporary. We want to see whether or not this is going to help. Because example of doing phenol, a phenol injection, which is an alcohol-based injection, that is more long-lasting. It can be anywhere from 6 months to a year to even more permanent than that. So we don't want to be giving that injection to somebody if it's not going to work. So lidocaine we could potentially do in advance, see if it works. If it does, then we know that the phenol will mostly work.
Gotcha. Okay.
That's an answer to your question, Terry?
Yeah, absolutely. And then the more invasive surgery that you're talking about, I think it was a nerve stimulator. It was on your slide.
Yeah.
Is that the epidural stimulator?
Yeah, so it's the intrathecal baclofen pump. So it's a pump that is surgically implanted usually into the abdomen, and then there's this tube or a catheter that goes from that pump all the way into the spine, and it essentially delivers the drug, in this case baclofen, into the spine continuously, or it can be timed throughout the day to help to decrease spasticity and uncontrolled tone in the lower extremities. So it again is later down the line because it's surgical, but from most of the patients that I have seen and have had that implanted, it can be very helpful to control some of that uncontrolled tone and spasticity. And
does it have the same side effects that taking a baclofen pill has? Yeah, so no, it does not. It's because it's going directly to the source, your spinal cord, and it doesn't go into your bloodstream, you're not taking orally, the dose is quite a bit lower, for one. Also, because of where it is and gravity, it doesn't have a lot of the same cognitive effects that baclofen pills do. So a lot of the drowsiness, a lot of the tiredness, the cloudy mental function doesn't exist at all with the baclofen. So that's a good thing. Mm-hmm. Okay, gotcha. All right.
You're muted, Terry.
Roderick, do you want to ask your
burning question?
Yeah, well, it may be inappropriate, but so yeah, I mean, I've had so much trouble with my spasticity, and I have had a trial of intrathecal baclofen, and you know, so I take 120 milligrams of baclofen a day. I don't actually know if it helps. There's so much fluctuation in all of my symptoms that it's really hard to tell if I reduce the dose and does it. I've never gone off it completely because it took me so long to get used to the sedating effect of it that it says, oh gosh, if I need to be back on it, it'll take me a year to get tolerance back. So. But when we've done the intrathecal baclofen, I actually had the opportunity where they admitted me to the St. Paul's pain management ward, and they put in an indwelling catheter. And I was in there for 3 days so that we could actually test what it would be like with the baclofen pump. But unfortunately, it was a long weekend coming up with the extra day being Friday. And so the end result was that we felt that we actually, although we had gone much higher than any of the standard test doses, what would be used for single shot testing, that we still hadn't really suppressed my spasticity and removed the tone, and hadn't encountered any serious side effects from it. So we never really got to an effective dose. And so eventually I arranged that we'd do another trial, but it was no longer possible to do the admission for the indwelling. And so it was going to have to be a single shot. And so that was done with the 50 microgram dose, is it?
That's right.
Yeah. And I guess by objective measure, it reduced my Ashworth score, but functionally, I mean, it certainly didn't take away my tone. I didn't actually feel any difference with me getting up and walking. And I guess the jury's out as to whether I use spasticity for walking or whether it inhibits me. My feeling is that it inhibits me. There may be components of my trunk stabilization and stuff that I'm not aware of that the spasticity is helping. But certainly my major spasticity is in my quads, and my full body weight is often needed to flex my knee, because there's enough spasticity in there. But that I do have enough volitional strength on the quads to stand. So I guess the end result was that, again, we felt that we probably still didn't get a high enough dose to actually really test it. And I guess at some point I'm looking at wanting to do another trial with
Higher dose,
higher than a standard dose, and just to see. But in the meantime, I've just been trying to get the best understanding of, well, okay, I guess the whole thing with me is I have these wild fluctuations in symptoms, and I'm trying to figure out, well, what's driving what. And I guess the better understanding I have of science's current understanding of spasticity, the better chance I have of trying to sort out all the complexity there. So I've been reading into it a bit, but I ran across that there didn't actually seem to be even a truly fully accepted, universally accepted definition for spasticity, in that it could be as limited as just essentially the lack of inhibition of the reflex arc, tendon stretch reflex, well, that's spasticity. So that because you're not inhibiting it, and the muscles are on or hyper-excitable to the reflex arc. But then it added in there that some people consider that it also includes the longer-term effects of it, which include things like weak actin-myosin bonds and something they referred to as myoplastic hypersmoothness. And I mean, are those things that get discussed clinically at all, or is that only at a research level?
I think that's more at a research level.
Okay.
I think that there is a general definition that we go on, which which you kind of summed up a little bit, but it's a part of the upper motor neuron pattern. It's a velocity-dependent increase in the reflex and the reflexes due to passive range of motion. But the definition has been unclear in that it has changed over time. That's the standard definition that we say. There are some modifications, things like that. But the aspects that you're talking about are all more just from a research level. Because clinically, what is the most important thing, right? And it's kind of what we chatted about. Whatever is causing that hyperexcitability is why the spasticity is worse. If we can find some molecular thing, if we can find something in the actin-myosin reaction that's leading to a worsened spasticity, then the researchers will help in that regard. But as research stands right now, I haven't seen anything in regards to targeting that helps with spasticity. Yeah. Sorry, my phone is ringing. Can I just answer that quickly?
No,
every time I answer, there's nobody there, so maybe I'm waiting too long. So, yeah, I apologize that, there's no target at that molecular level that I know of right now in the research to manage spasticity better.
Right. Okay. No, it totally makes sense to focus on the things that we think we can handle.
Yeah, and that's the clinical piece right now. And as the research continues, maybe something will happen, as you say, with the dopamine receptor antagonist with the pramipexole. Like maybe that is an avenue, right? But that requires research. That requires more to figure that piece out. But you two right now are two people who are saying that is helpful, and that is clinically good to know.
Yeah, so I just quickly Googled the pramipexole and MS, and I guess it's a little disheartening to see that their discussions of its use in MS are actually more based around its effect on the T cells that are actually driving the MS itself. So while lots of solid reasons why it would be useful in MS, probably not so much so for us in the spinal cord.
Exactly. So that's why I have seen it used before. I mean, it's not a first-line treatment or anything like that, but it is something that I've seen used in MS before.
Right.
But in spinal cord injury, I have never seen it used. I have never prescribed it thus far. But again, Patty is somebody who has MS. You are somebody who does not, but it has been helpful to you, and that's good to know.
Yeah, although it might be more pre-existing movement disorders.
Yeah, sorry. So you're a special case. You have a 2-for-1 reason.
I'm a special case. I've been told that.
I mean that with care.
No, that's great. Thank you.
Awesome. Thanks so much, Roderick. All right. Well, last call for any sort of questions that anyone has. If you want to just raise your hand or whatever, I might be able to see you. I really want to thank Dr. Chan. Thank you so much. It was very informative. There have been some people that asked to get a copy of your slides. So if you could email me, and I will send it out to the group if you like. Obviously, also I'm recording this too, but it does take a bit of time to get put up on YouTube and stuff, but I'll send out the link as well. And I know Dr. Chan also did say that if anyone had any questions after this, please just email me and I'll forward them on to him, and he'll be happy to answer any other additional questions that you have. Thank you everybody so much. And that includes you, Linda. I'm sorry that we didn't get to hear your voice. Anyways, thank you so much, everybody. Thank you, Dr. Chan, again. It was really informative, and have a great day and a great weekend, everybody. Thank you.
Thank you, everybody. Take care.
Bye.